Hi everyone, in today's video we're going to review the updated Pediatric Septic Shock Algorithm, starting right now. Hi everyone, before we dive into the algorithm, first a couple of scary statistics. Every year in America, about 7,000 children die from sepsis. If a child dies in the PICU, it was most likely from sepsis. Globally, around the big blue marble, sepsis and infection accounts for over half of all pediatric deaths on the planet. So it's huge. Now, if you're looking at the older septic shock algorithms, you can see they've been updated dramatically. And it appears that a lot of these recommendations have come from the Surviving Sepsis campaign, which is a global effort to help improve survivability pediatric sepsis. Another thing to consider before we dive into the algorithm is who's managing this kid. The good thing is we don't have to manage pediatric septic shock every day. The bad thing is we don't have to manage pediatric septic shock every day, so none of us are really comfortable doing it. You want to get an expert involved immediately, start taking direction from that expert, and making arrangements to get that kid out of there to the appropriate medical facility, a pediatric specialty hospital, to manage this kid. That said, let's dive into the box, which is concerned with box number 1, recognizing pediatric sepsis. So first thing, altered mental status. This kid looks sick, right? He may be altered a little bit. He's not with it. He's not acting appropriately. Not surprising, many of these septic patients start out as respiratory infections. Staph and strep are common bacteria that can cause sepsis in a child. And it's going to start as respiratory, and we know this. With kids, it's all respiratory. So be looking for that. Altered mental status. Hypo or normal tension. Now, when it comes to hypotension, as an instructor, when I send my students up to the ER for rotations, sometimes I don't see a blood pressure on this kid, and I'm like, hey, where's the blood pressure? And we all know that children are able to maintain, through peripheral vasoconstriction and increased heart rate, they can maintain a blood pressure until they tank. However, in sepsis, we need to keep one eye on that pressure all the time, and we're using it to judge how our child is recovering. Now, there are no greater variables in vital signs than in the pediatric patient. Now look at all these pediatric cuffs here. We have to make absolutely certain that if we're taking a non-invasive blood pressure on this small child, we're using the right size cuff. And the only way to get good at this is to practice it. Make sure you're using the right size cuff. Now, if you're on a transport team, you want to correlate that new cuff you're putting on them based on what they had before you put the cuff on. So correlate your findings between what the child just had and on your new monitor. A lot of times we can just take the same cuff, put it onto our gear, and we're good to go. But that pressure has to be correlated before we leave. Peripheral pulses. Do they have delayed capillary refill? Now you can blanch the fingernail. It's going to turn white. You release the pressure, should flash pink within 2 seconds. Great capillary refill. Okay, looking at box 2, this is associated with our initial treatment, our initial stabilization of this child. First things we want to do, 1, get him on a monitor. Make sure that monitor is going to telemetry or central station so everybody can see it. Monitors should be up like in most ERs so everybody can take a look at that heart rate. We're going to monitor their pulse oximetry and oxygenate as appropriate. We want to get capnography on this child so we can look at their ventilatory status and maybe little clues into their acid-base status. We want to watch that blood pressure, and again with a properly measured non-invasive blood pressure cuff. And then just support their general ABC. So we're going to start that immediately. We want to gain vascular access on this child as quickly as we can. IV is still preferred to IO. IO is great if that's what you can get, but an IV, like something in an antecubital, the largest catheter we can get in this kid would be preferred. Next, fluid management, which is the cornerstone of treating septic shock. We want to start tanking this kid up with IV fluids. 10 to 20 mLs per kilogram. Now it used to be everybody knows 20 mLs per kilogram in a kid. Great. Where'd the 10 come from? Well, if it's a neonate, we're going to use 10 to start with. 10 mLs per kilogram. If the child has a known underlying cardiac issue, we're not going to put that whole 20 in. We're going to throttle back to 10 mLs per kilogram, and we really have to watch for pulmonary edema. It doesn't take much to take a kid with a bad heart, tank them up with IV fluids, and then put them into pulmonary edema. And in fact, every time you administer a fluid challenge, you have to go back and listen to those lung sounds. Now, another thing I like is keeping one eye on that respiratory rate. Way before we start developing rales or cardiac pulmonary congestion, you're going to see that respiratory rate start to climb up. So, get a baseline respiratory rate, set it 4 above, and set an alarm for it. Or however you want to adjust it, but you have to look at that respiratory rate and have some alarm to indicate, yeah, their respiratory rate's going up. This way we can stay ahead of, look at their lungs, and not throw this kid into pulmonary edema. Okay, moving into box 3, this is going to be our treatment for the first hour. We're going to begin our treatment starting with getting some labs. We're going to get a full panel of labs. We have to get blood cultures drawn immediately. Obviously, we're going to take a chest x-ray on this kid. Next, the administration of empiric broad spectrum antibiotics. We want to start treating the underlying cause of the sepsis, which is the bacterial infection. Now, if you're somewhere where you can't get labs drawn right away, you can't get your cultures drawn right away, do not delay administering the antibiotics, because that's the treatment. We're fixing the underlying problem. So administer your antibiotics. Obviously, we'd like to get the cultures first. Treat the child's fever with antipyretics. Continue our fluid boluses. Again, reassessing in between each administration of a fluid bolus. And then go back up to box 1 and keep looking for those signs and symptoms. Is anything else new popped up? Are we moving in the right direction? So we're constantly reassessing after everything that we do, reassess the child. And that's a good place to start, box 1. That's what we're looking for. Okay, moving into box 4, this is really looking at the fluid resuscitation portion. And it's asking, has the child received between 40 to 60 mLs per kilogram of IV resuscitation? Now the 40, of course, would be either a neonate or a kid with a heart condition. So we're looking at that 60 mLs per kilogram, which is going to reflect 3 20 mLs per kilogram boluses. So they got their 3 repeat boluses of crystalloid fluid. Have they gotten better? Which goes into box 5. So if they've got their fluid resuscitation and they got better, how do we know they got better? We reevaluate everything from box 1. And if the child has improved, they're still going to need an expert consult, because why did this kid get sick in the first place? And we want to make sure we adequately manage that event so the child doesn't become sick again. Moving on to box 6. This means they've gotten their 3 bumps of 20 mLs per kilogram and they're still not doing well because items from number 1, box 1, are not improving. At this point, we need to go to pressors. And the recommendation is initially you can go use either epinephrine or norepinephrine. However, the scientists from the surviving sepsis study recognize that there's no real studies that show which one is better than the other. However, they recommend, if this is high cardiac output and peripheral vasodilation, a warm shock, that probably norepinephrine would be preferred to epinephrine for that vasoconstriction. Norepinephrine has more of an effect on the vessels than it does on the heart when compared to epinephrine. So again, box 4, have they been fluid resuscitated? 5, they look good, still get an expert consult. If they don't look good after fluid resuscitation, we gotta look to start pressors. Okay, this has been a quick review of the updated Pediatric Septic Shock Algorithm. I'm Mark, thanks for watching, see you in the next video. You release the pressure, should flash pink within 2 seconds. Great capillary refill.